Healthcare Nutrition hosted webinar. I am absolutely thrilled to have with me this evening Robin Pauc as our main guest speaker. Now, for those of you who don't know, Robin actually trained originally as a chiropractor, and he now specialises in childhood developmental disorders, and he's here to talk to us this evening about his very wonderful and highly effective integrated approach to managing and restoring optimal health in these poor children who are obviously suffering, and their families who are suffering along with them. So welcome, Robin. Thank you for being here.
That's a pleasure. Thank you. Okay. So
sorry, I will pass you without hesitation over to Robin, and he can start his talk and tell you all about what he does. So it's over to you then, Robin.
Okay, so right. First of all, good evening, everybody. They actually have a slot booked this evening for 2 hours, but I don't know what it's like with you, but here it's absolutely gorgeous. It's boiling hot. So I've trimmed it down from 2 hours to 10 minutes. So anybody who wants to get to a barbecue or slip off to the pub will be able to do that. I'm joking, unfortunately. Okay, so this evening we're going to talk about the learning and behavioural conditions of childhood. And to start off, for anybody who doesn't know who I am, this is me. I'm the exceptionally handsome guy on the right. This is a picture taken from a new book. So this is a little plug I've put in there. It's a new series of books for children all about learning and behavioural disorders, and the little chap in the middle there is called Bad Elf, and you'll be seeing a little bit of him later on. So that's me, and what we're going to do today obviously is talk about learning and behavioural conditions, but basically what I want to start off by asking a couple of questions. So if it were possible to show patterns of comorbidity, so for those of you who don't know, comorbidity means when you have more than one condition at the same time. If there was a comorbidity between the learning and behavioural conditions of childhood, one, would it help us understand the underlying cause? And would it also help us to provide effective treatment? One of the things that really sort of annoys me is that so many children are given a diagnosis of dyslexia, dyspraxia, attention deficit, whatever, but then there's very little that actually happens to help the child after that, because just giving a child a label doesn't actually tell you what the underlying cause of their issues is, and if you don't know what the underlying cause is, then it's pretty difficult to actually treat them. Now, historically, I taught clinical neurology, and in those days, I prided myself that I had a pretty good understanding of clinical neurology, and I could explain it fairly well. So, for instance, with, say, Parkinson's disease, one of the common problems is that the person wants to initiate a movement, they want to walk, whatever, but nothing seems to happen. Now, I could explain to my students quite easily that basically when you send a motor command down to a motor nerve, at the same time there's a feedback loop from the motor nerve to a thing called a Renshaw cell, and the Renshaw cell then inhibits the motor neuron from being fired again. So it's like putting on the handbrake. So when you send a new message down to the motor neuron, you have to send a parallel message to switch off the Renshaw cell. In other words, if you're going to drive away in your car, you have to take the handbrake off. So I could explain things I thought fairly logically. However, when I started teaching the learning and behavioural disorders of childhood, I really struggled, and I thought, well, no, I must be pretty dim, I can't understand this stuff. But what I rapidly learned was that a lot of other people, the majority of people, also didn't understand. Now, there's a theory, rather like Murphy's Law or whatever, and I can never remember what it's called, but there's a theory that you actually get promoted in life until you reach your level of incompetence. And I thought, well, I must have reached that point. Anyhow, one day I was sitting somewhere, I won't tell you where I was sitting, But I had this sort of eureka moment where I suddenly thought to myself, I wonder if instead of all these things, dyslexia, dyspraxia, tic disorders, OCD, instead of being actual disease entities in their own right, supposing that they're symptoms, and symptoms that always appear in patterns of comorbidity, would that make a difference? So just like Rodin sat there thinking about creation of the thinker, I had this eureka moment and went away and looked at patterns of comorbidity. Were there patterns of comorbidity? Did they actually exist? And so I produced research papers to show that this does actually happen. So this is Rodin's thinker, and it's probably the same position that I was in when I had my eureka moment. So we're going to look now at a study that I did some time ago. Basically, we had a group of children who'd already been diagnosed. So what we did was we looked at those children under categories of things like dyslexia, dyspraxia, etc., and said, well, okay, they've got this primary diagnosis. Have they also got other criteria for other conditions? So if we look initially at children diagnosed as having dyslexia, you'll see here 84% also had the diagnostic criteria excuse me, for dyspraxia, 62% for ADD, attention deficit, 21% for attention deficit hyperactivity disorder, 16% for OCD, 6% for a tic disorder. If we now look at dyspraxia, so the primary complaint that the child's been diagnosed with is dyspraxia, 70% will also have the diagnostic criteria for attention deficit, 50% will also have a diagnosis for dyslexia, 36% for ADHD, 21% for OCD, 17% a tic disorder. Now these are significant numbers, and what you'll notice as we go through this, one of the most common things that's at the top of the board is dyspraxia. So if we look at attention deficit hyperactivity disorder, 89% of these children with a primary diagnosis of ADHD also had dyspraxia, 64% also had attention deficit, 30% dyslexia, 18% a tic disorder, 14% OCD. Primary complaint, attention deficit, again 86% had dyspraxia, 44% had dyslexia, 32% attention deficit hyperactivity disorder, 20% OCD, and 18% also had a tic disorder. If we look at tic disorders themselves, so this is primary sort of tic disorders, and as well included within that we had Tourette's syndrome. So primary disorder, tic disorder, 80% had attention deficit, 80% also had dyspraxia, 38% also had attention deficit, 24% dyslexia, 12% OCD. Now, because of these clear patterns of comorbidity, I decided, this is way back, a few years back now, that the better thing to do will be to say that these things are not conditions, they are symptoms. They're symptoms that appear together, and it's better to describe the whole thing as a developmental delay syndrome. If you say a child has a developmental delay syndrome, you can say, this child has a development delay syndrome characterized by aspects of dyslexia, dyspraxia, attention deficit, etc. It's better to do that because then you get an idea, a picture of what is happening in that child's brain. Now, the learning and behavioural disorders of childhood are very, very common. Figures from around the world would suggest that in the region of 1 child in every 5 experiences some form of learning difficulty or behavioural problem. And they're so common that in some situations they're considered to be normal developmental stages. So it's not uncommon for a child to go through a stage of being clumsy, to have a minor tic disorder, excessive blinking, particularly when tired, little bits of OCD-ish in their rooms, wanting things to be just so. Not unusual at all. Normally kids pass out of it, but a significant number of children retain these symptoms and therefore need help. So basically, as I said, the learning behavioural difficulties as we understand them, in my mind, do not exist. They're not diseases, they're just symptoms. And they're symptoms that never appear alone. They're always in patterns of comorbidity. Now, the symptoms of a developmental delay can be attributed to specific areas of the brain. Now, the areas of the brain affected are those that are directly affected by the process of Bpoptosis, and I'll explain what that is in a moment, and secondary areas that are affected by what is called a diascasis. Now, a diascasis is basically, if you imagine if I had a factory that was, say, producing motor cars, but I got the seats for the cars from a factory, say, in Sheffield. If the factory in Sheffield went on strike, they probably have some stock they could send me. I'd probably have some stock in the warehouse. But if I couldn't get the chairs, the seats for the cars from somewhere else, and they remained on strike, my production will cease because I can't produce cars without seats. So this will be an example of a diascasis. Now, the most common place in the brain to have problems is the cerebellum, notably the left hemisphere, and that will affect the right side of the brain. So one of the things that happens to all of us in life is a thing called apoptosis, which is programmed cell death. Now, what happens is that basically we produce millions and millions and millions of brain cells. Some of them aren't perfect. Some of them get lost in migration because they have to travel from where they're produced to where they're going to live. So they can get lost. Some of them, once they get to where they're meant to be, don't make friends. And if you don't make friends, if you don't have what's called synaptogenesis, then you're going to die. So you produce millions and millions of brain cells, but a good number of them will actually go through this program of programmed cell death. Now, the unfortunate thing about it is you might lose 10%, you might lose 20%, you might lose 30% of your brain cells. So from that point onwards, no man is born equal. Now, the second word that I mentioned earlier is Bpoptosis. There's no such thing. It's just a word I made up because B follows A. So I've been told off by many academics saying that it's not correct, but it's just a little joke on my part. Bpoptosis is the word I coined in 2005, and it's a word to describe the window which occurs 4 months to 4 years postnatally. Now, in that window, new brain cells are produced, notably things like the von Economo cell. These brain cells have to, again, be produced, they have to migrate, they have to make friends. So, for instance, with the von Economo cell, which is one of the most studied, it has to pass to the dorsal lateral prefrontal cortex, so the outside wall of your temple. It also has to go to the inside wall of the brain, notably to an area called the anterior cingulate, and they also have to end up in an area called the insula, and there are fields in those 3 areas of the brain. During the research that's taken place, notably since 2005, other brain cells have been discovered, things like the calcium binding calretinal cell, and other cells that were discovered earlier have come to the light again, because quite often people discover things and it just ends up on the shelf somewhere and it gets forgotten. So this new wave of research that started in 1995, another little revival in 97, and then from about the year 2000 onwards, a lot of change has taken place, a lot of new research, and our understanding of how the brain grows and develops has changed significantly as a consequence. So Bpoptosis is the production, migration, and synaptogenesis of second generation brain cells. That's very important because it's fairly recent that this work has been discovered. Now, something you may be aware of, because there's been a lot of interest in this, is what's called epigenetics. Now, we used to think in days gone by that DNA was destiny, that if you had a problem written in your genes, that was it. Now we know, thanks to research that's taken place in the field of epigenetics, we know that DNA is not destiny. So basically our DNA, specifically the 25,000 genes identified by the Human Genome Project, is now widely regarded as the instruction book for the human body. But what we have to bear in mind is that genes themselves need instructions. They can't just work on their own. They need instructions for what, where, and when to do things. So they have to be instructed to do things, and we'll give some examples of that in just a moment. So is it genetic? The new thinking now is that there are only about 2% of all conditions that are truly genetic. In other words, if it's written in your genes, you're stuck with it. Epigenetics may well transform how we think about illness and how we go about treating it. So it's a new science. It's only been going a few years, but it has, I think, a tremendous future. So let's look at how it works. The epigenome you can think of as being really a group of protein switches. And the epigenome controls morphogenesis, both in the uterus and in this postnatal growth period. And it does this via the activation of what is called HOMEOBOX genes. Now, one of the interesting things is, and something that certainly got me very excited a few years ago, was that the suggestion that certain stressors might inhibit the normal activity of the epigenome. So the epigenome's got to switch on the genes. What people have been saying, and certainly some of my research would agree with this, that if you have a stressor of some sort, and it can be a birth problem, it can be food problems, whatever, we'll talk about that in a moment, what it can do is it can cause the epigenome to glitch. If the epigenome glitches, then the actual development of gene activity will be halted or delayed. So it's really, really important that we don't stress the epigenome. So the epigenome has to trigger what are called HOMEOBOX genes. So a HOMEOBOX is a DNA sequence found within a gene that's involved in the regulation of development, morphogenesis. So the epigenome switches on the HOMEOBOX genes. The HOMEOBOX genes then cause a cascade effect by triggering the activity of other genes which are needed for the production of whatever. So obviously when you're in the womb, you've got to decide when to grow your ears, your eyes, your arms, your legs. No point getting to 8 months into the pregnancy and thinking, wow, no legs. You know, you've got to do it when it's the right time. So it's the epigenome triggering HOMEOBOX genes that causes all this to happen. Now, obviously, when you're in the womb, things have to happen. What we didn't realize until fairly recently was that amazing changes have to take place, not only to our body in terms of the body getting bigger, but our brain has to go through amazing changes to get to its adult form. So basically, the brain grows and develops round about 9 years of age. Certain parts of it hardwire. The brain then continues to grow until you're about 16. Between 16 and 19, it gets pruned back again. And then between 19 and 25, it then goes on to mature. So it's a long growth process, a long juvenilization process where the infant is dependent upon its mother for a long period of time. during this time, because it's such a long period of time, lots of things can go wrong. There's the potential there for things to go wrong. So one of the things that can alter, or several things that can alter the genetic expression, but one of the things that's received a great deal of research is maternal stress during a specific window of gestation. Now, a lot of research has been done into things like viral infections, particularly in the study of the causes of autism. There's lots and lots of research papers out on that. Premature birth. Not so long ago, I always say it was like last week, but time flies when you get to my age. I'm nearly 30 now, so time goes whizzing past. So probably 2 years, maybe longer. Some research work was done in Sweden, and what they found was that we used to sort of think in premature birth as being 36 weeks or below a certain weight. What this study in Sweden told us was that if you're born just 1 week early, so if you're born at 39 weeks, the probability of having a developmental delay increases. 38 weeks, 37 weeks, 36 weeks, 35 weeks. So the probability of problems increases. So premature birth is certainly a factor. Just going off on a tangent for a moment, in theory, and this is purely in theory, we humans should remain in the womb for probably something like 22 months. Now, there are very few mothers on the planet who would agree to having a 22-month pregnancy, and obviously they couldn't feed the baby, it would be impossible, and they couldn't carry the baby, and even if they did, they couldn't give birth to the baby, it would be too big. So premature birth, anything less than 40 weeks basically increases the probability of developmental delay later on. Fetal distress, the child gets stuck in the birth canal, or the cord is wrapped around the neck, or they produce meconium. Anything like that raises the probability quite highly. Birth intervention, so this is use of forceps or ventouse. Ventouse suction in particular raises the probability of fetal distress quite significantly. Something like 42–44% of children that are delivered by a suction delivery, particularly the ventouse, have an intracranial bleed, which is obviously not good news for the child. So interestingly, when I worked in Algeria, they said that it was against the law to use suction ventouse in Algeria because of the high risk factors. That's quite interesting that in some countries they don't allow its use. So what are the other factors that could possibly cause a problem? The modern diet is one thing. Historically, when we were hunter-gatherers, according to anthropologists and what have you, we had a very, very good diet. We went out looking for food, scavenging, and finding a whole mix of things. Once we settled down and became farmers, our health declined. So changing over from scavenging to having a cereal-based diet wasn't good for us. Following the Industrial Revolution, lots of people left the countryside, moved to towns, and so food had to be produced in vast quantities. And then, of course, we had the advent of the supermarket. And once you have a supermarket, you have to have food, all year round. It's not seasonal food. It has to have a long shelf life. It has to be brightly coloured, all sorts of factors. So there are 2,500 chemicals which are allowed to be used in the production of food. So this is where your E numbers come in. Also, there's a huge amount of bad fats in food that's produced in this way. So the modern diet isn't good, well, not as good as it would have been if we were hunter-gatherers. We've got lots of bad fats. We're having less exercise, eating the wrong foods. We're getting lots and lots of problems with obesity. With E numbers, originally E numbers were tested individually. It's only in the last few years at places like Southampton University they've looked to see what happens if you actually mix E numbers together, and particularly if you add things like artificial sweeteners to them as well. So what they're finding now is that in certain combinations, E numbers are very bad news. So that's a possible factor. The use of artificial sweeteners, I mean, they're just everywhere, not just in fizzy drinks and what have you, but in things like Calpol, in sweets, in foods, all sorts of things. The world we're moving into, more and more like this webinar, relying upon computers. So much of what we do now is electronic. We use computers, we use iPhones, all sorts of stuff, and a lot of kids play lots and lots of computer games. Going off on a small tangent, computer games are actually good for you. They're very good for hand-eye coordination. They make you think quickly. But after about 30 minutes, the effect changes. And instead of being good for you, there's a particular part of the brain that hyper focuses. And that's when it's almost like an addictive thing. The child doesn't want to let go of the game. So I always say that if a child's going to play computer games, 30 minutes is absolute maximum. So that's not good. And of course, kids aren't getting out, having exercise, having fresh air. They're spending too much time sat on their bottoms watching television or playing computer games. So these are all factors in the modern life that could contribute to stressors. And this is Bad Elf again. And here he is. This is lunchtime. He's in school and he's having his packed lunch. So he's got his jam sandwiches, his crisps, his sweets, his chocolate muffin, and his cheese strings, which probably don't contain any cheese. So if we look at fetal distress, here are some figures that came from the study I did way back. And what you'll notice here that with pure fetal distress, the main sort of thing that's likely to result from it is a tic disorder and dyspraxia, although dyslexia and attention deficit are still fairly high up on that one. With birth interventions, the picture changes somewhat, and it's attention deficit hyperactivity disorder that shoots up, but verbal dyspraxia, tic disorders, and attention deficit still pretty high on the list there. Now, what I said earlier was that labeling children is all very well and good, and in many ways you have to do it, because if you want to get help in school, if you want to get your child statemented, whatever, you need to have a diagnosis. But does that actually help the child? Wouldn't it be better if we could relate these individual symptoms to specific regions of the brain, understand why it's happening, where it's happening, and then have the option to do something about it, put it right? So what we'll do is that we'll look at some of the common conditions now and write a few mistakes that have been made and maybe sort of float some ideas as to what we should be looking at, rather than just saying, oh yeah, it's this, it's that. Now, a lot of knowledge gets embedded in textbooks and it stays there, and we learn mistakes. So it's best to be a free thinker. So let's look at dysgraphia first of all, struggling to write. Now, common mistake. It's commonly assumed that if you're right-handed, that it's the motor areas of the left cerebral hemisphere, the left side of the brain, that initiates and controls writing. Well, that's wrong. The motor areas of the left cerebral hemisphere certainly do control the right arm, but it's this little bit here on the right side of the brain that actually controls the fingers. So in that area, which is the mid-cingulate gyrus, this is motor areas at the top, and the bit just beneath it, so in this bit just here, this is the mid-cingulate gyrus, there is a group of cells which are called gigantopyramidal cells, and they're the things that actually control your finger movement. So this is the area that gives you fine motor control. So if you're suffering from dysgraphia, left side of the brain is controlling the arm, but the right side of the brain is controlling the fingers. So let's look at that in a little bit more detail. So first of all, common thing you notice with children that are struggling to read, a lot of them have a fist grip. Now, a fist grip is very, very useful if you want to hold a rock and bang somebody over the head with it, if you want to hold a big stick to hit somebody or an animal with, if you want to use a spear, or if you want to use a dagger. Very useful. Not if you want to hold a pencil. So the fist grip basically says those little, huge cells, gigantopyramidal cells in that little field in the mid-cingulate gyrus, if they're absent, then you have to use another area of the brain. And that other area of the brain doesn't know about delicate, fine movements. All it knows about is roughy-toughy stuff. So if the gigantopyramidal cells are not in Brack's area, in that field of gigantopyramidal cells, then you have to use alternative areas, and the alternative areas will use the power grip. So that's very common. The other thing that's commonly seen is the claw grip. Now here what you see is that the elbow, the wrist, the fingers are all held in flexion, bent back on themselves, so the child's almost writing sort of finger level with their forearm. The reason that happens is that the back of the brain, the cerebellum, each hemisphere, right and left, sets the tone for the muscles on the same side of the body. So right cerebellar hemisphere sorts out the muscle tone for the muscles on the right side of the body. Now, if we look at the arm, there are more muscles on the front of the arm, this is with your palm facing forward, than there are on the back of the arm. So when you send the tone down to those muscles, what the brain has to do is send a message down to attenuate the tone in the flexors on the front of the arm. Now, if that doesn't happen, you've got the same amount of tone in all the muscles. The more powerful muscles overpower the weaker muscles, the extensors, and you end up with this flexion of the elbow, flexion of the wrist, flexion of the fingers. So not only are you holding the pencil or pen in a really strange way, but you end up with the infamous writer's cramp, because you've got so much tension in the muscles and the grip is so tight that your arm ends up aching. So to have a normal grip, you have to have the gigantopyramidal cells, you have to have a left hemisphere that's working properly if you're right-handed, you have to have a cerebellar hemisphere that's working properly to produce the tone that you require. Many children have hypertonia. And you also have to have a brain that's working sufficiently well to attenuate the power of the flexors in the arm. If you can do all of that, you end up with a normal grip. So next, let's look at dyspraxia. As you probably noted earlier, it's the most common comorbid symptom. It's up sort of like 70–80% with pretty well every other condition that there is. So we look at dyspraxia now. It takes many forms, and what's tended to happen over the years is more and more sort of descriptions of dyspraxia have, more and more names, terms have been pulled out of the hat. I don't know if you noticed recently, but the DSM-4, the Bible of Diagnosis, has been superseded by the DSM-5, which is a much smaller, thinner volume, and a lot of the older terms are being taken out now, because what was happening is that people were constantly coming up with new terms to describe new presentations of symptoms, and it was just really getting quite silly. So what we need to do is look at underlying causes, and the best way to do that is to think of these things as being symptoms, not actual conditions. So we'll look at dyspraxia in a little bit of detail, both the gross and fine motor skills that are associated with it. So in order to understand dyspraxia, we have to understand about the timing of the body. And the timing, as far as the motor system goes, starts off at the bottom of the brainstem. At the bottom of the medulla, we have on each side a little nucleus, a little group of cells called the inferior olivary nucleus. And what's really sort of interesting about the inferior olivary nucleus is that it pulsates spontaneously. So just like with your heart, you don't have to say beat, beat, beat. Hopefully it just does it on its own. So the inferior olivary nucleus pulsates. Now what you want is the two inferior olivary nuclei to pulsate at exactly the same speed. So the pulsation needs to be between 8 to 12 hertz, but it needs to be doing that equally on both sides. Now what happens is each inferior olivary nucleus sends a pulse to the opposite cerebellar hemisphere. The cerebellar hemisphere then sends a pulse to the opposite red nucleus, and the red nucleus is at the top of the brainstem. The red nucleus then sends a pulse down on the same side, ipsilaterally, to the inferior olivary nucleus. So it's like a triangle which goes olivary nucleus, cerebellum, cerebellum, red nucleus, down to the olivary nucleus. Just turn the page. And this triangle has been called the circuit of Guillain-Molleret. And basically what it does is it sets the timing of all motor activities by turning on, turning off the motor system ipsilaterally. So each side is turned on, turned off, hopefully at exactly the same time. And it's because of this that we have the physiological tremor, which is obviously that thing. I don't know if you've ever noticed somebody when they're sitting with their one leg crossed over the other, you see the leg bobbing up and down. Well, that is because the system's being turned on, turned off. Now, basically, every motor activity that you enter into has to be initiated as the system is switched on and stops as the system is switched off. So it's absolutely crucial, critical, that the two sides of the brainstem, the inferior olivary nuclei, are pulsating together so that you're setting the exact correct time frame so they're in sync together. Now imagine what would happen, particularly in terms of fine motor skills, if the two olivary nuclei were out of sync. Imagine, for instance, doing up or undoing a button. You've got two very different sets of motor activities to complete, but it's got to be done in exactly the same time frame. So one hand has to hold the shirt, the other hand has to hold the button, and then you have to pull the shirt, push the button at exactly the same time so that it actually comes undone or gets done up. Now, if it doesn't work, you end up with what used to be called addressing dyspraxia. So really, really important that the two sides of the inferior olivary nucleus work together, because that means that the cerebellar hemispheres are working together, and that is essential because we've got to set the time not just for motor activity but for brain activity as well. So looking at the timing of the brain, the timing of the motor system by the inferior olivary nucleus also sets the timing for the thalami. Now you've got a thalamus on each side of the brain. Each thalamus needs to be oscillating at 40 hertz. Imagine again what would happen if the two hemispheres of the brain were completely out of sync. And what I often say to people is, imagine that you're sat in your office working on a project. I'm sat in my office working on a project. I'm on page 1. I don't know this, but you're on page 2 because you're more efficient than I am. And I just don't understand paragraph 3. So I ring you up and I say, what do you make of paragraph 3? So you look at paragraph 3 and you tell me something and I think, what are they talking about? I'm looking at page 1, paragraph 3. You're looking at page 2, paragraph 3. Two totally different things. Now, may not sound terribly important, but if the brain goes out of sync on each side by just milliseconds, the brain then gets terribly confused because the two sides are completely out of kilter, out of sync. So it's really important that we get the inferior olivary nuclei working properly so that the hemispheres of the cerebellum work properly, so the thalami can work properly, so that the brain, right and left, can work properly, because they each have different functions, but they have to talk to each other all the time. And if they're out of sync, you're going to have a problem. Okay, so let's look now at another common thing, dyslexia. They reckon that between 30 to 60% of children currently considered to have dyslexia have in fact convergence, convergence insufficiency. Convergence insufficiency basically means that you can't bring your eyes in towards your nose equally and accurately. So when you're looking at something close up, you're looking at a word on a page or a number, whatever, both eyes have to come in, so both eyes are looking at the same target. Now, what happens is the eyes look at hopefully the same target. The image of that target gets projected onto the retina of each eye, but it has to be in what's called within Panham's area. Now, Panham's area isn't a physical area, it's degrees of accuracy. But if one eye is slightly off to the side, it's not going to be looking exactly at the target. If it's way off target, the brain will say, right, we can't deal with that, and it will shut down the data from the aberrant eye and only take data from the good eye. So it's really important that both eyes can come in, both look at the same target at the same time, in order for the child to be able to get whatever it is on the page off the page and into their head. Now, the interesting thing is that convergence insufficiency can be diagnosed in a matter of minutes and treated effectively in a matter of weeks. And it would appear to be a problem associated principally with what's called the paravermal zone of the cerebellum. Now, I say apparently because there is a fair amount of research that's been done, but for some, I don't know, strange reason, the cerebellum still seems to be an area of the brain which is still full of mysteries. New things are being learnt about the cerebellum all the time, and we're learning more about how the cerebellum functions and what effect the cerebellum has in talking to the opposite cerebral hemisphere. So very interesting area of the brain. But the paravermal zones, which I'll show you where they are, so they're the bluey bits on this picture. So that's looking at the cerebral hemispheres, right and left, and then the blue bit is the paravermal zones. The greyish bit through the middle is called the vermis. So it's thought that it's the paravermal zones that talk to the nuclei in the brainstem. The nuclei in the brainstem then talk to the muscles that surround the eyes and cause contraction. So what you need is the medial recti of each eye, the muscles on the inside, on the nose side, to be stimulated equally and accurately so both eyes come in towards the nose to the same degree. Now, if that's not tricky enough, once you've done that, if you're going to read, you're then going to have to hold the eyes in convergence and move them like windscreen wipers left to right so that you can read. So an enormous amount of control has to be put in place, principally by the paravermal zones, but also by other areas of the brain. Now, usually it's the left eye that struggles to converge, and the reason why that is that normally in a learning or behavioural issue, at least 97, if not more % of children will have a problem with the left cerebellar hemisphere, right cerebral hemisphere. It's just the way it goes. The right side of the brain is very different from the left side of the brain. The right side of the brain we used to think of as being more primitive. Now we know that in fact that's not the case. The right side of the brain has to deal with everything that's new, whether it's a new situation you end up in, a new building, meeting a new person, learning new information, looking at something that's different, all happens on the right side of the brain. Once something's familiar to you, it then swaps over to the left side of the brain. And that explains why so many children prefer routine. They don't like things that change, because if it's routine, if it's something they know, the left side of the brain can deal with it. If it's something new, something challenging, then the right side of the brain has to deal with it. And if you remember earlier, I mentioned von Economo cells, which were rediscovered in 1995 and have been extensively studied since about 2000. Those cells, you've got 15% of them when you're born. The other 85% develop in that window of Bpoptosis 4 months to 4 years after birth. Now, you would think that these are the most sort of all singing, all dancing, latest special brain cells to develop, to evolve. You'd think you'd stick them all into the left side of the brain, where we do in most people all the clever stuff. So language, mathematics, theory of music, all the clever stuff happens on the left side of the brain. But no, there are more of them on the right side of the brain, because the right side half of the brain has to react faster than the left. So if you're going to make a snap decision, are you dangerous? Do you like me? Do I need to approach or run away? It's got to happen really, really fast. The left side of the brain has got time to think things over. And, the sort of thing we say, I need notice of that question. That's the left side of the brain's job. Immediate, quick response is very much the right side of the brain. And for those of you that have read things like the chimp paradox, the chimp lives on the right side of the brain, on the inside wall, the medial wall of the brain. And it's very much the thing that responds very, very quickly to new situations, potential threats, whatever. So if you read Steve Peters' book, The Chimp Paradox, that's where the chimp lives. Okay, so going back to convergence insufficiency, as I said, it's an essential precursor to smooth tracking and thereby reading fluency. And it's often associated with very poor visual attention, which we'll talk about in a moment. Visual attention, visual fixation, the ability to keep your eyes where they're meant to be, normally takes place around about 5 to 6 years. So before that time, you have a visual defensive reflex. After that time, you have the adult form, but we'll talk about that in a minute or so. So while we're talking about areas of the brain and what have you, very interesting, I was talking to a friend of mine, a colleague the other day, and she was saying that she's starting a research project in Japan. And apparently the professor in Japan she's going to be working with said to her, well, of course, he said, we don't believe in dyslexia. We think it's visual recognition. Now, it's very interesting because, as you'll see in a minute when we talk about another area of the brain, we're taught traditionally that vision is all about the very back of the brain, the occipital cortex. But in actual fact, there are other areas of the brain, for instance, in the parietal cortex and in the temporal cortex, which are involved in vision, but not in vision as in I can see you. They're involved in vision in other ways, in detecting movement or detecting shape. So one of the areas that's very important in terms of reading is the back end of the temporal lobe. And in that area, there's a thing called the parvocellular area. And it's a region of the visual system. And it's the area that frightens you to death when you're walking down a dark country lane and you suddenly spot a bogeyman and you suddenly realize in actual fact it's a bush. Now, it's very primitive, it's designed to defend you. So if you're in a forest, in the jungle, and there happens to be a big bear or a wolf or something, you can identify that shape by its outline and then look at it to realize that there is a potential danger there. So that's why when we frighten ourselves to death, it's always something really, really scary, because it's very primitive brain. It's suggested that what we've done is we've overlaid over that primitive defensive reflex the ability to identify shapes, and shapes in the form of words. Now, the reason that the professor in Japan was saying that they don't believe in dyslexia is because with Japanese writing, it's almost like it's a pictogram. And so what you're doing is you're looking at a picture as opposed to a word that's formed with letters. And so what we do is we go through this whole boring process of learning C-A-T spells cat. Once we've learned it, and as adults, we don't look at the individual letters, we look at the shape of the word and we identify the cats on the mat. And that's why you can read a great big word like chrysanthemum, but you could say to a lot of people, go on then, spell it, and they go, oh, right, C-R, no, C-H, C-H-R, C-H-R-Y. And say, well, come on, you just read it. But if the shape's right, where the individual letters are is not that important. And so it's probably this area of brain, this parvocellular area, that actually, once we've learnt to spell, actually identifies the word. So I went off on another tangent then. Okay, so in terms of assessing convergence insufficiency, because if 30 to 60% of children have this problem, you need to be able to identify it very easily. And there's a thing called the Binocular Visual Assessment. It's a computer-generated test. The child wears 3D glasses, looks at the screen, and there's 3D images produced on the screen that get harder and harder and harder to see. And the child has to say whether the box, which is in 3D, is at the top of the screen, the bottom, the right, the left. Then all of a sudden they lose it, they can't see it. And then you make it easier and easier and easier, then they can see it again. So you can measure what's called base out and base in very, very accurately in fractions of a diopter. So you can do manual testing for convergence, what have you. But you can also use things like the binocular visual assessment to work out exactly in fractions of a diopter how bad the problem is. And you can also use it as a monitor for progress. So once you put treatment in place, then you can actually use a BVA to monitor how much progress is being made. And we use, again, computer-generated treatment programs, absolutely ideal because the child can use it at home. The one that I usually recommend, which is called Engaging Eyes, is fun because the child splats aliens, blows up targets, has fun. So it's a bit like playing a computer game, but built into it is the treatment, and the child has to get gold stars, has to win a trophy and all the rest of it. So the ability to make rapid eye movements, the ability to converge, diverge, the ability to hold convergence and track is all built into the program. And over a period of a matter of weeks, most children with convergence insufficiency can be treated to the point that they pass the visual assessment, and they can then move on, and then we can look in other areas of the brain, see if there are any other issues. But most kids, just having done that, their reading age will jump up quite dramatically. So let's look now at attention deficit, and you'll see on the slide here it says attention deficit question. One of the tests that I do for all children is what's called a confrontation test. I sit staring at them, they cover one eye, and I bring an object into their peripheral vision, and they have to tell me when they see it. Now, kids with visual inattention have to look at something that moves into their periphery. So basically, it's a retained primitive visual defensive reflex. Now, we have to have that, because if we go back to the time when we were hunter-gatherers, if mum puts baby down on the floor of the cave while she's doing her dusting, and a wolf or a bear appears at the door of the entrance to the cave, the child has to notice the movement, look at it, scream, and then an adult defends the child. That's how it should work. Now, basically, this visual reflex should change from being a primitive reflex to the adult reflex when the child is between 5 and 6. Now, if that happens, all well and good. If it doesn't happen, every time there's a movement in the periphery, the child can't help but look at it. So here we see a little picture of the brain. So this is the outside wall of the brain. The area we're talking about now is up here in the parietal cortex. It's called the magnocellular area. The bit we talked about earlier for word recognition is down here in the temporal cortex. That's the parvocellular area. So we're going to be talking about up here in the parietal cortex, the magnocellular region. And this is the bit that's really, really important for visual attention. Okay, so what happens is the magnocellular areas on each side, right and left, monitor what's happening in the opposite peripheral visual field. So they don't see, as in I can see you, I can see the screen now, whatever. What they detect is movement. So if you put your hands level with your ears and wobble them, You know their hands, but what you're actually seeing is movement. So you're not seeing fingers and whatever, you're just seeing some movement. So that's your magnocellular area working as it should do. Now, for a hunter-gatherer, very, very important, because if you're out in the forest hunting for food, something could be hunting for you as a tasty morsel. So anything that moves in your periphery, you have to detect. Any unusual shapes in your peripheral visual fields, you have to detect. So the magnocellular area, detecting movement, the parvocellular area, detecting outline, shape, very, very important for your survival. But in a busy classroom, to have a magnocellular area that isn't working properly is a complete pain in the what's-it. So you need to have that area working properly, because otherwise the child can be misdiagnosed as having real attention deficit as opposed to having a problem with visual attention. So round about 5 to 6, what should happen is the right magnocellular area, so the right magnocellular area should become the executive. It decides, do you need to look or not? So if you were talking to me, telling me something really important, you'd expect me to keep looking at you, nodding, saying, yeah, I'm listening, I understand what you're saying. If I suddenly looked away, you'd think, oh, he's not interested, or that's very rude. So my executive should be able to keep me looking at you, ignore a bird flying past the window, ignore someone walking past the door. But if something slithers on the floor, then I've got to look at it, because that is a potential danger. There shouldn't be a snake in this room. Okay, so lastly, let's, because we've been talking, or we've been together now for nearly an hour, so let's talk about Sweaty Betty. We all know children that have sweaty palms, sweaty feet, smelly feet. They tend to be children that are easily agitated, and it's not unusual for them to have morning tummy ache, which in days gone by used to be called abdominal migraine. Now, there's a particular part of the brain. So if you cut the brain in half, look at the inside wall, you've got that white thing in the middle, the corpus callosum, which joins the two sides of the brain. The front part of it bends down, and it's called the genou, the knee of the corpus callosum. The bit that's just in front of the knee, we call the perigenual area. And the one on the right side is involved in processing emotion. And it's also, very importantly, the area of the brain which switches on the sympathetic nervous system. Now, the sympathetic nervous system, pretty well everybody knows, is the fight or flight response, the shoot or scoot. So basically, if it's activated, you are then in a much better position to stand and fight your corner, or to get the heck out of it, run away as fast as you can. Now, when there's a raised level of activity in the perigenual area on the right, a partial sympathetic response can occur. So you're not switching on the sympathetic system completely, so it's in full-blown mode, but it's ticking over faster than it should be. And for those of you that are old enough to know about old-fashioned cars that had carburetors that you could tinker with, sometimes you had to make the engine tick over faster or tick over slower, and you did that by tinkering with the carburetor. Well, sometimes in the human brain, bits of the brain can tick over a little bit faster than they should do. Interestingly, the anterior cingulate, which is the area just behind it, if it underfunctions, you become hyperactive. If the perigenual area, this bit where the sympathetic bit's coming from, if that becomes more active than it should be, then you get this sympathetic response. So you're not in full sympathetic mode, but you're more likely to respond badly to a situation because you're in this fight or flight mode. So this can lead to excessive sweating, raised heart rate, raised respiration, agitation, being on edge. But the other thing is, and this is really important, is that when you activate the sympathetic system, you inhibit what's called the enteric system, the gut system. So the autonomic nervous system is divided up into sympathetic, parasympathetic, and the enteric system. Now, the enteric system is pretty much autonomous. It just gets on and does its own job. When you're relaxed and whatever, the parasympathetic system allows the enteric system to get on and rest and digest, and everything's fine. Once you cut in the sympathetic system, then the enteric system gets shut down, because you don't want loads of blood going to the gut. You don't want all the activity involved in producing food. You don't want a bladder that's full of urine, bowels that are full of feces. So if you get really, really frightened, you wet yourself, you have an accident, because you need to empty the system. And the reason why, when you get nervous, you feel really, really sick, is that as you shut down the enteric nervous system, the blood supply to the gut is shut down, and the blood gets shunted off to muscles, parts of the body where you're really, really going to need it. So it's a really, really important thing that has to happen. But one of the things that can happen is that children can get tummy aches in the morning if this system is being overactive. So we're nearly at the end of this little talk. So one of the things that really gets to children is stress. So a child that's being bullied, has got a test to do at school, or is struggling in school, feels that they're stupid, that they're not, not as clever as the other kids, can have this psychosomatic response of getting tummy pains. And the interesting thing is that okay, some kids can swing the lead. They're smart enough to sort of make out they're ill when they're not. But a lot of kids, it's genuine. They really are in discomfort. So you say to the child, okay, if you've got a very bad tummy ache, you stay in bed. You don't need to go to school today. I'll bring you up something in a minute. When you go up sort of 20 minutes, half an hour later, there's the child sitting up in bed, absolutely fine, no problems whatsoever. And you think, oh, little devil, they had me. But no, what's happened is, as soon as you take away the stress, they're not going to go to school to be bullied. They're not going to go to school to do the test. They're not going to go to school to struggle. As soon as you take that stress away, that area of the brain settles down. The sympathetic response stops. The enteric nervous system goes back to normal. Now, if that doesn't happen, if you have a child that you say, no, you're going to school, go on, off you go. The other thing is that when you put the peritoneal area under stress, one of the things it does is it sends a message to a thing called the nucleus accumbens. And the nucleus accumbens is in front of two parts of the basal nuclei. And what it does is it feeds information into the nucleus, and within it you have got what are called striazomes. So within the striatum you have the striazomes. The striazomes are involved in recruiting muscle fibers. So if you've got to do something really, really important, like fight for your life or run for your life, what you want is to have your muscles functioning at the highest level. Now, if you've got a child that's stressed, and I mean, we're not saying just minor stress, but long-term stress, the peritoneal area feeds information into the nucleus accumbens. The nucleus accumbens feeds information into the basal nuclei. The basal nuclei then put more strength into the muscles. So the child is not only on edge, but has become a highly effective warrior because they can move faster, hit harder. So a child that is stressed in this way can, in fact, become quite aggressive. And some of the behavior you see in children, you can relate it to these little areas of the brain that we've been talking about. Now, that's an hour and 5 minutes of me talking. I think we've all had enough stress for the day. I don't know about what it's like with you. Here in the New Forest in Hampshire, it is a perfectly glorious evening. So I think what we'll do is we'll call the webinar to an end. I will take questions. So if you'd like to have a question, ask me a question, that can be done, and I'll do my best to answer you. Thank you for listening to me, and if you have a question or two, please post it for me.
Thank you very much for that, Robin. That was really, really fascinating. I mean, certainly from my perspective, I'm really interested in neurology and how that impacts on everything. So I was really interested to find out that actually all of these conditions that we associate just with, like you say, sort of you're born with a susceptibility, it's your genes that control it, but actually there are things going on in the brain, and there are things we can do to alter those. So you talked very much about the kind of biological basis and what's going on in the brain and all of the signals and the chemicals that are sort of interacting. Can you give us just a really brief overview of how people might start to address these chemical and electrical issues and signaling issues in the brain and start to calm things down a little bit and start to resolve?
Yeah, I mean, it's very, very simple, and the starting point in terms of treatment with pretty well every child that comes to my clinic is we look at their diet. Quite often kids will have cereal for breakfast or skip breakfast. Breakfast is the most important meal of the day because basically most kids haven't eaten for 12 to 14 hours, so the digestive system is empty. What you need to put in at that time is protein, fat, carbohydrate. A child's diet needs to be different to an adult's diet. So what we need to do is start the day with complex foods, not processed foods. That's really important. Mid-morning, piece of fruit. Lunch, good school dinner or sensible sandwich, some fruit, some raw veg. A gentle snack in the afternoon, not things loaded with sugar, and then a sensible home cooked meal in the evening. Now, if we do that, we're giving the body, in terms of foods, everything it needs, because it's got to have proteins, fats, carbohydrates, roughage, minerals, vitamins, all the things that, you know, you nutritionalists know about. The other thing is that the brain is very, very, very dependent on omegas, zinc, magnesium, vitamin C, and B complex. 60% of the brain is made out of fat. Of that fat, 20% has got to be omegas. Now, if you have an appalling diet, you're probably having too much omega-6. You certainly won't be getting enough omega-3. And as you well know, research that's been done has suggested that the higher the content of EPA in your omegas, the better they work. And the research that came out of America last December suggested that if you're having an omega that's high in DHA, it raises the probability, and it only raises the probability of prostatic cancer. So basically, change your diet so that you're having the right foods at the right time of the day. Take a good quality omega, and I and I have to mention the company, don't I? I have to say Bpoptosis. So, but
only
the other
because
thing,
it's the one you use.
it is, that is true, and it's in my new book as well. Second
Yay.
plug. But also
What's
the
the
anterior.
called, Robin?
Well, there's a series of books. The one that's coming out shortly, it'll be available as an ebook in the next 2 to 3 weeks. It's called
Super.
Good Elf, Bad Elf, because it's all about elves and fairies.
And brilliant. And it's specifically for children to read.
It's for children 6 to 9. So the younger ones, Mummy reads it to them. Full of humour. There's humour for little children. So people are called Ram's Bottom, Long Bottom, Thistle Bottom, whatever. There's humour for the older child, and there's humour for the adults who are reading it. So younger children, mum or dad reads it to them. Older children read it themselves. And as you saw the illustrations in the PowerPoint presentation, I found this chap in Essex who does these, I think, brilliant illustrations.
Yeah, they're fantastic.
There's just humour all the way through the books. So hopefully, say 2 or 3 weeks, we'll have the ebook available, and then the paperback will follow. So that one's called A Picture of Elf, and then there's book 2, book 3 following on after that. So what it does is it informs children and parents, but the main point of it is to inform children as to why they're having problems and what they can do about it. But also it deals with things like obesity, bullying, the importance of friendship, And so basically it not only tells the child that may be suffering why they're having problems, but it also explains why the child in the class may have a tic, maybe suffering with a bit of OCD, may need a friend. It's basically to inform children about sort of what may be happening to them. So they're there. So going back to what I was saying about diet, very important. Omegas, very, very important. You must have zinc and magnesium in your diet. There are places in the world where all the children are bouncing off the walls, and it's because they don't have enough zinc and magnesium in their diet. So the anterior cingulate is very, very dependent upon it. For the production of most neurotransmitters, you need zinc, magnesium, B6. So you need to have these things in your diet. So that will be the starting point. Basically, diet, supplements. And then in some of my books, if you look at things like Could It Be You, in there it tells you how to do a little bit of diagnosis for working out how the cerebellum's functioning. And then there's some simple physical exercises that you can do at home that will help you to help your child. So diet, supplements, some simple physical exercises. If there's more of a problem, I've got 3 major books out. There's Is That My Child, The Brain Food Plan, Could Be You, and then we've got this new series of children's books coming out shortly. So you can certainly read the books. I've got a website you can visit. There's lots and lots of information on the website. And of course, you can contact me. I'm here pretty well every day of the week, and I'm always up to chat to people.
Super. Well, thank you very much for that, Robin. Because it's such a lovely evening where you are, I won't keep you any longer. I'll let you go off and enjoy the sunshine. Unfortunately, here in Cambridge, it's chucking it down with rain, so I won't be going to spend any time tending to my veggies.
The sun shines on the righteous, and it's making my broad beans and my runner beans and my dwarf French beans and my chard and my spinach look fabulous.
I'm sure it is. My broad beans are already been and gone, so obviously we've not got the right sunshine up here in East Anglia at the moment, but the courgettes are coming along nicely. Anyway, I shall leave you in peace, Robin. Once again, thank you so much. Perhaps we can do another webinar in a month or two's time and go through a little bit more into your therapeutic approach and techniques and the nutrition basis.
Absolutely. I mean, what would be really good would be to talk about these what people call conditions, but which actually are symptoms. But if we took a symptom, inattention, problems with reading, whatever, if we looked at that and then said, well, okay, this is how you would identify it, this is how you treat it, because there are very, very simple ways to approach so many things. So yeah, that would be my pleasure.
Fantastic, because I'm sure an awful lot of the practitioners here tonight and who will listen to this in the future will identify with even adult clients who experience a lot of problems that I'm sure your techniques and your interventions could benefit them. I know there are certainly a few things that struck a chord with me that I suffered from as a child. I was never diagnosed with anything specifically, but thinking back, there are things that I definitely think, oh yeah, that was probably me. So it would be really interesting, I think, from everybody's perspective to find out a bit more about, like you say, the individual symptoms and how you might go about resetting that and addressing that. So fantastic. Well, we shall all look forward to that. That would be a pleasure. Super. Okay. Well, as I said, I shall leave you in peace. Thank you again to everyone for attending. You can get in touch directly with us at iGenis or directly with Robin through his website. It's the Tinsley House Clinic, isn't it? The website. Tinsley.
Yep. www.tinsleyhouseclinic.co.uk.
Super. And yes, Robin is generally very, very good at responding to emails quickly, so I'm sure he'll be happy to answer questions. So have a lovely evening, everyone. Those of you that can go and enjoy the sunshine, please do. Those of you, unfortunately, that it's raining for, it's supposed to be sunny tomorrow. So thank you for coming, and we will see you all again very soon. Take care, everyone. Good night.